Bienvenue à la session scientifique du Département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du Département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki ekoweshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Well, good morning, everybody, and welcome to Family Medicine Grand Rounds. Happy New Year. We've taken a break over the summer, and this is our first session back for the academic year. It is my pleasure to be the moderator of today's session. My name's Doug Archibald, and I am the Director of Research for the Department of Family Medicine. And I'll be joined today with two esteemed folks in our department. The first is Dr. Madeleine Montpetit, and she presently works as a clinician teacher at the Riverside Family Health Team. And over the last many years, she's held a variety of leadership positions within the Department of Family Medicine. Her main area of scholarship has been medical education, in particular supporting learners in difficulty. She's recently accepted the role of complex system navigator for the college's Outcome of Training project and is excited to help facilitate the transition towards a 3-year residency training program here at the DFM. Dr. Liddy, as we all know, is our chair, and she is a full professor here at the University of Ottawa, Department of Family Medicine. She's also a University of Ottawa research chair and e-consult in primary healthcare. She's a senior investigator at the C.T. Lamont Primary Healthcare Research Center, 3-year Research Institute, and practicing family physician at the Ottawa Hospital Academic Family Health Team. And the three of us are going to be talking today about Team Primary Care and the Outcomes of Training project. And I'm just going to share my screen. All right, so today, this is how we're going to divvy up things. Over the next hour, I'm going to give a quick presentation. It'll be an overview of Team Primary Care and the Outcomes of Training project, the second phase of the Outcomes of Training project, which we're in right now. As this is Grand Rounds, I'm going to be talking a little bit about developmental evaluation. It's how we are going to be evaluating this whole endeavor. I'm going to talk a little bit about how we're collecting and interpreting our local evidence here at the University of Ottawa. And I'm going to share with you a proposed model for what this 3-year training program can look like. And for the majority of the time, I'd like to spend in a discussion. So I'll facilitate that discussion, and Madeleine and Claire are here to answer questions that you may have. So don't let me talk any more than 20 minutes. So let's go back. I mean, why we can do all this work that we're doing actually comes from a $45 million grant from the federal government. This funding is for team primary care. The primary investigators are Ivy O'Anderson, Nancy Fowler from the college, and Ivy Bourgeot from the University of Ottawa. They're sort of the primary recipients of this grant, which went to the college. And it's enabled us this year to do what we're doing. Now, I think everybody's familiar at this point with the Outcomes of Training project. Madeleine's been since the end of February has been promoting this endeavor. But it is part of a larger project, Team Primary Care. So Outcomes of Training project, of course, are the curricular innovations across the 17 family medicine programs across the country. But Team Primary Care, all right, it is a series of projects and endeavors. Many of them have to do with curriculum of allied health being involved in primary care, more of an integration into primary care. So that's there's projects around nursing, around pharmacy, occupational therapy, respiratory therapy. There's a whole list of projects that are going on. So it's all about reimagining, designing our curriculum. A particular focus for us right now have been these first two priorities that you see on the screen: improving preparedness of our family medicine residents for community needs, and optimizing scope of training. As we proceed, we also need to consider working in interprofessional teams. That's the third priority that you see here. And then, of course, 4 and 5, improving social accountability and health equity. Now, come March, we're going to be putting forth to the college a curriculum renewal plan and also a change readiness assessment for how we are going to be moving forward in the future. Now, as I said all of this, I should say that I didn't put a conflicts of interest up on the slide. But from this Outcomes of Training project funding, I do receive a stipend for my work as a developmental evaluator. However, majority of that does flow back to the department. So, Outcomes of Training project, hopefully this is all familiar to you. It's about moving towards a 3-year residency program in family medicine. Reason being, curriculum is full. And Madeleine's been talking about this. Time is the resource here. And it's not about adding a 3rd year. It needs to be much more than that. It's not about doing more of the same. We're wanting to re-envision what things are all about. It's about optimizing scope, enhancing skills, and better preparing our graduates to work differently in healthcare. Now, to help orchestrate this program, we have an Outcomes of Training project team. Complex System Navigator is Madeleine. We have administration and management. and that's Ashley Montpetit and Marissa Duval. We have a curriculum design team, many of which are on the call here right now. And that's our curriculum director, Denise Lewis, Ed Seals, part of this. Kendall Noel, I saw, is on the line as well as our assessment and evaluation director. And there's many others that play a key role in how we view the curriculum design team. I'm the developmental evaluator, and I'll talk about what developmental evaluation is in just a bit. But essentially, I help to view all the evidence for us moving forward and help put it together in a report. And I put here this part in bold. The outcome of training project is for all of us, and it is all of us. Everybody here on this call, everybody in our department is part of this transformation going forward. This is a slide that Madeleine has showed. Phase 1 of the outcomes of training project, this has happened over the last number of years, where the college has done a needs assessment to look at scope of training. In fact, we know that in Canada, we have the shortest training period for family medicine in the world, yet we have the largest scope of practice. So as we said, the curriculum's full, and we need to look at a longer training program to do everything that we want to do. And there's evidence to show that this does work. So the college also has produced reports looking at the evidence from across the world for expanded training programs. And that really brings us to what we're doing now, which is curriculum renewal and change stewardship. And this phase carries on until the spring of 2024. The college has said, well, what could this possibly look like in this evidence? And as you can see here, maybe the beginning of a 3-year program, it's about enhancing foundations, and then the second and third year transitioning into practice. And we've been working with gathering evidence over the past number of months in our department to actually work with this to create a curriculum model. But what does this mean, really? Well, there's a lot of implications for us in our department and more broadly in the faculty of medicine, and also more broadly into the community. What does this mean? Well, it does mean we'll have increased family medicine learners. First of all, there is an immediate expansion from this year over the next 3 years. And then once we're in a 3rd-year program, I mean, that translates to probably about 50% more residents. So there's more numbers. So we do have to consider, well, building capacity. That's a consideration. Consideration, how do we better train for complexity? Big issue here is forging partners. I shouldn't say issue, I should say opportunity for forging partnerships. And of course, bridging the specialist versus community care divide, right? There's a great opportunity here as we move forward to a 3-year program. As I said, I wanted to talk a little bit about developmental evaluation. So as we're looking at the outcomes of training project, how do we go about perceiving it? Now, I think everybody's here is familiar with program or traditional program evaluation, where it could be an internal person like me or somebody that's external, and they observe, they collect evidence, and they make judgments or recommendations, really from a judgmental type of perspective. Developmental evaluation is not that. Yes, data is collected, but there's also informal feedback continually. So I'm involved in all our outcome of training project meetings, and I do give feedback. I give feedback to Madeleine, I give feedback to Claire, to the team as we progress. So the evaluation happens actually before, during, and after implementation. So my work actually will carry on over time. Another piece here is that the evaluator is subjective. Michael Quinn Patton, and if you just Google him, he's sort of the father of developmental evaluation. And he's actually part of this larger team primary care project. He speaks of the evaluator as someone who has both skin and soul in the game. And I see myself as having skin and soul in the game. I'm very much embedded in the department, and I really want to see our department succeed as we move forward to the outcomes of training project. So my role is one that's very subjective. But the types of questions that I'm asking overall, I'm looking about how our innovations in the Department of Family Medicine, how they're changing over time. And that's really what I'm exploring and looking. How can we change? How can we improve? And I want to say this endeavor for team primary care, it's the largest developmental evaluation that has happened ever. You can be assured that there are going to be many publications that come from this because honestly, the world's watching as to what we're doing here. So as I said, it's very subjective. It's a strength-based approach to evaluation. You may have heard of the term appreciative inquiry before. That's the approach that we're using. Many traditional data collection methods that we would use in research, we would use in an evaluation such as this, right? So I'll be talking about some of the surveys that are running. I take field notes. I make observations, reflections. Most of our interactions so far have been through observation and through meeting notes. This is our approach using Cotter's 8-step process for leadership change. And you can see here in our timeline, we're right in the middle here. Up until this point, Madeleine's been going out on road shows and promoting the outcomes of training project. We've sent out a survey to preceptors that is based on the residency training profile. So getting a sense of how preceptors feel that they're able to provide opportunities for residents to complete the core professional activities among the domains of care. And now we're now moving towards this model for what a 3-year program looks like for us. It's going back to the unit level to see how this resonates. And that information will, of course, be shared at the next big event, which will be our department assembly at the end of October. And then as you can see here from the assembly through to the end of the year and to the beginning of next year, it's about putting it all together. So what do we do well? Where are the gaps? And I've mentioned here, there's been a number of forms of evidence that we've used. First sources of evidence actually came from the first phase of the OTP, which did identify gaps across our programs. And so there's some priority areas that we need to examine, and I'll share those in just a little bit. Curriculum mapping. Denise Lewis has been very active in doing this for us, looking at what we do in our curriculum programming and mapping it to these domains of care. We've had a whole series of road shows that have been led by Madeleine Montpetit, getting input from our faculty at the local level. Is just so important. Residency training profile surveys, which have been completed by our preceptors. So far, we've got well over 50%, and more surveys actually are trickling in. So that hopefully will be able to get that closer to 100% by the end of the day. So we really get a good snapshot from our preceptors' view of how we're doing. The Family Medicine Longitudinal Survey. I'm going to show a couple of examples here of how this survey complements our core professional activities, all right, and complements the views or perceptions that our preceptors have, right, by our residents. And then, of course, the outcome of training work meetings. These are the minutes that are taken, my observations and reflections. And then coming up, the DFM retreat. I won't be there personally on Saturday and Sunday, but Marissa and Ashley and others will be there capturing this information and then relaying it to me. So these are, remember I said in the first phase, the college, they had done a lot of work to really identify, where the perceived gaps across the country are. And you can see I've listed them here. Two that I want to zero in on are Indigenous health and health equity and anti-racism. So these two, I'll show some examples of how these surveys can help shed light into these identified gaps. What we did for this is we just took the core professional activities and sub-activities, put them into a survey monkey for our preceptors to look at. And they had to look at these core professional activities and identify, well, do they offer this opportunity? Or do they not offer this opportunity? And if they do not personally offer that opportunity, does their residents have some way of getting this information, or obtaining this these skills, the skills and knowledge for that activity? So this is a shot, as you can see here, at the point that I took this information, we had 83 preceptors had answered this question from across our department. And so for this core professional activity, number 9, provide medical care that challenges systemic racism and supports health equity for Indigenous peoples and other racialized and underserved patients in our communities, in these communities. And you can see the sub-activities below. So we can see at a department, we cover this very well. But there is some red, right, where it's not done, and there's some yellow. So we're able to tease these out a little further, and we can do that at a site level. So I'm going to take the first two here, providing cultural and psychologically safe care experiences for patients and families, and provide trauma-informed care experiences for patients and families. I'm going to look at that in a little more detail. So at the site level, okay, and you can see I've de-identified the sites. Now we actually have 11 sites. The 11th site here, it is Montfort. Their preceptors did this in French, so they're not on this slide. They are incorporated into the larger data set, but you don't see them here. So you can see for this sub-question, providing cultural and psychological safe care experiences, we can see where the green and the yellow is and lies, and that can give us some insight. Likewise for B, we can see that it's predominantly green, but we can see where the yellow and red areas are. To give us further insight, preceptors were able to descriptively comment, and you can see here some of the comments that we had. Local community is not particularly diverse, but residents visit healthcare facilities in Akwesasne. Would be better if community residents from the burbs could have a rotation in the inner city and vice versa. Okay, so there's some good ideas that are being generated here. Again, this gives us some further insight. Now, what I've done now is I've gone to the time 3 survey of the Family Medicine Longitudinal Survey, right? And time 3 is a survey that's sent from the college. It's not sent from us, but it is sent to our former residents. So those residents that have graduated between 3 and 5 years. And they're asked a whole series of questions. This particular one, which of the following domains of care do you consider to be part of your family practice? So I look at the response of Indigenous health, and you can see, and again, our sample here is fairly small, but from 2019 to 2021, you can see that more respondents than not don't provide Indigenous care or health than those that do, of those that responded here. Then there's another question. If you answered no to that question, if you had more training, would you be providing it? And you can see here that only a few selected yes here. So they feel, these residents that have graduated feel that they do receive enough training in Indigenous health. So you can sort of see here how the Family Medicine Longitudinal Survey can complement our core professional activity survey. What do we know so far? Well, we know that nationally, programs are struggling with certain key priority areas. The CVFPC is going to help us here. They are going to be compiling guidelines in these priority areas that I shared earlier to help us share resources and expertise and teaching opportunities. And the other message that I want to get through here is that we have a great program here at U of Ottawa. We just need to do a little tweaking. So here is our proposed curriculum model. You can see it's on a continuum. It starts with a transition to family medicine. So a core idea here is that we want to sort of have an expanded boot camp at the beginning. So all our residents are in family medicine. They're not in their external rotations. They're with us for sort of this mandatory family medicine boot camp. So they're grounded in the culture of family medicine. And then there's a transitioning here into core family practice. All right, so we're proposing sort of our current 2-year program with some minor modifications, and then moving into a transition into practice. So this is about increasing levels of independence. Possibly there's some selective or electives that these residents are able to do. They're more involved in teaching and supervision of junior learners. Resident-led clinics are another idea that has been circulated. And really, it's about consolidation of skills, being confident and competent into practice, becoming practice ready. Questions for us to consider today. And Claire and Madeleine are going to be hopefully answering some of your questions, concerns, and fielding ideas too. I think this is what we want to do. We want to look at, what is our program going to look like in your current context? Does this make sense? What excites you about this? Right? What are some quick wins? As I said, we've got a very strong program here. All right. Right. We want to continue that, and we want to keep that. Who should we partner with? So I brought up Indigenous health. Are there partnerships that we can foster better here? And what are our opportunities for growth? So that's where I'm going to leave things. And now open the floor.
Hey, Doug, thanks for that talk. This is Matt. I'm one of the PGY2s at Bruyere. I'm just thinking about that first question about how this applies in our context, thinking from the resident perspective. I see you involve you involve some recent graduates with some of the surveys. Are you involving any current residents, or is there any involvement of current residents here in some of these things?
Doug, do you want me to grab that one?
Please do, Madeleine.
Okay, so we actually had set up that we'd start the conversation at an academic day, and unfortunately I got COVID 2 days before that happened. So that's being rescheduled. We're going to certainly in the very near future go into the academic day and open up the discussion. At every level, the hope is that we will bring residents into the discussions around curriculum and the curriculum reform. We're having conversations at the undergrad level as well, because you have to start, you guys are going to be done. You will be the ones that will inform us as how well you're taking advantage of the opportunities for putting in pilot projects. But certainly those medical students starting first year this year are going to be the ones that will be in the new curriculum. So we're starting in undergrad and looking at, okay, let's talk about what this means. Certainly there's a lot of misinformation around right now. So the more people understand the goals and the intent and the mindfulness and the slow, methodical process we're using, I think the more they'll feel comfortable that this is the right decision to increase preparedness.
think that's a great point. You're definitely right. You need to involve the current medical students and the residents and have that open discussion and spread accurate information. Because a lot of us don't really know what these proposed plans are going to be until this session, at least, was helpful for me.
Oh, good. I think the more we can bring people in, certainly at the college level, learners are on, within the discussion, and that's certainly the approach we're taking, is that nobody's left out. And what I'm starting to do as well is involve a lot of our allied health and interprofessional teams, because they're going to play a part in the curriculum as well. So my team at the Riverside is very excited to get involved in any way they can and start pilot projects, because that's another focus on how do we make this work for the educational component, but also the primary care reform, so it's sustainable and that we can actually make changes through education at the level of, primary care, right?
Yolanda.
Morning, this is really great. We had a really good discussion about this at Primrose yesterday with Aaron and Sohail, going through some of the slides that you showed today as well. I guess maybe, Madeleine, I would ask, I know that over the last number of years, I think many people in academic family medicine have felt that a lot of our residents end up doing sort of a third year, like extra training, focus practice. So I wonder how much you guys are thinking as well about maybe allowing in that third year, if people have, interests in a certain area, like let's say OB, just, because that's close to my heart, as people know. Do you envision that maybe people could also, like, even though I know part of the goal is to continue to do comprehensive care and, broad scope practice, but also maybe if they do have an interest to be able to sort of focus as well and then be finished after 3 years, either like having that focus or, combining a practice of some kind?
That's really the question that's out there. And we presented at the postgrad executive directors for Faculty of Medicine yesterday. And again, that question came up, and it's really about, preparedness so people can practice within their designation as a family doctor versus the enhanced skilled, right? So then where do we form a hybrid? Do we form a hybrid? Do we encourage people? And for example, I'll use my palliative care. I didn't do a fellowship in palliative care, and yet I did enough experiential learning and learning on my own and mentorship that I was able to become a consultant in palliative care at the hospital. Now that means that as a family doctor, I'm able to then feel comfortable and feel prepared to use those skills in a way that's meaningful to me in passion that I have. That doesn't mean that I'm at a point where I can be the leader in the community and be able to solve the problems of other family doctors that are feeling comfortable doing their own palliative care, but are maybe unsure of their ability to deal with complexity, right? So for the college, this is really kind of a moving target. And certainly I know there's frustration at the level of the enhanced skills directors, because it really leaves them into, in a position of where do we fit in this? At the University of Ottawa, all of our directors of enhanced skills have been so lovely at saying, we want to be part of designing something for these third year residents that helps them feel more prepared to do this. But where does that leave us as the leaders? And what does it mean in terms of the commitment for our particular skill set? And certainly there's discussion about, okay, who has to be another, fourth year, and where could we incorporate a stream of some of these enhanced skills into a third year and still have a designation? So great question, but I wish I could give you a more solid answer. There is none right now. I don't know if Lindsay's on the line. She's certainly part of that discussion as director of our enhanced skills.
No,
Madeleine,
I don't see her medal.
Maybe I'll jump in too. So again, great questions. And I think what I wanted to encourage though is that I think at the University of Ottawa, we're really open to, as Madeleine said, trying some things out. So let's demonstrate or do, a phase 1 of what that might look like. And I think we've talked about the idea that, and we're already doing this with the hospitalist experience out of the MAL4, that, if you already identify as you come in as an R1, that's an area where you want to develop expertise, that it could be an integrated actually from the beginning. So that's one example. That's a little different than, what you might do in a more phased, third year added on to a traditional residency program. But open to both, right? And then the other piece that we've been thinking about is that the way that the third years right now, like honestly, some of the units when we went to visit, and then also nationally, there's a really high proportion of the second year residents who actually are applying right now for enhanced skills along many of the different areas, like very high proportion. Over 50%, 60%. There's not that many spots that are available. And the only options on that, unless you can do your tailored program, really is to define an area. So what if, as part of that, we tested and created an opportunity where, in fact, you could do your enhanced skills in a formal tailored comprehensive family medicine, tailored to then, as you said, okay, actually, I'm going to be, I would like to do more obstetrics, and, I'm going to either integrate that or do that as a comprehensive, an additional third year of training. Maybe we could flip the, this is sort of the logistics of it. And I think what I want to say is that I see this as being possible for people who would like to, have some program design ideas and want to, as Madeleine said, test it out. So our environment here is very favorable and really open to working with you with those ideas and seeing where we get to, realizing that the College of Family Physicians, what they're doing is they're going to be changing a standard in terms of what the training needs to look like in the future. And so we want to be, I think we're looking at being ready to then meet that change in standard, but it doesn't mean that or what I would like to encourage is that we're going to try some things out before. And that's where, again, Matt, back to your question, and I think the involvement of students and involving our medical students, what do you think it would look like? Would you like to try, on a small scale to actually just do some program design, self-tailor it within the context of what we're trying to achieve under outcomes of training? So maybe we flip some of the positions that we're getting extra ones, and create those opportunities, which would mean that the funding is already there. So all options on the table, think outside of the box, bring your ideas. This is the perfect time because what Madeleine and the team have been doing is essentially doing, let's get what's happening in Ottawa, which is fantastic. So we have an amazing program. And then what are the possibilities?
And just maybe to add a little bit to this, I met with Bill Hogg, and Bill's on the line, I see. And really it's about, we met about the clinical scholar program, and we had a discussion about, okay, what could this look like? But you are the people that can determine what this looks like. So if you present a proposal and, you've got a group of people that are willing to do a pilot project, well, let's get to it, because the next the next 3 years is really curriculum design, but this is an ongoing process. This is QI forever. Why not start the project now as a pilot project and then do proof of concept and move forward? And if you can get people together that are, like-minded and passionate about that approach, then why not start now? Because we're putting together a repository of all those exciting projects that are out there. And we're happy to be part of helping you pitch it so that you know exactly what we need to move it forward. I think I saw David and then Claire, but I did want to answer Erica's comment about are we moving things into the community? I think we've all agreed through the roadshow that third year needs to be grounded in community. And that is really the important thing I want everybody to understand, is that we really want to build this comprehensive, prepared, training program. People can choose to have focused practices after, but if you are prepared and you are comfortable with being comprehensive, it's more likely you're going to add more elements to your practice scope when you graduate. So, changing the environment, and I think I'll share one of Ed's comments is we also want to put in the, and forgive my language, but the oh shit elective, so that you actually are pushing yourself to be empowering yourself to be more than what you potentially would be in the program we have right now.
I've already put some global notes in the chat there, but being at the college, I really support your methodological and slow approach to this. I think Yolanda's hit a key question on the head, and that is, how do we combine this with enhanced years that currently exist? I think if we start saying that you can get an enhanced year after the regular 3 years, then we're potentially giving the message that the regular 3 years that's being created is not really core. That's the conundrum. And we're potentially devaluing the whole enterprise. At the same time, moving an enhanced year to a 4th year is clearly distasteful to a lot of people, despite global trends, right? The Americans are moving from 3 to 4 years just for their core program. We clearly have to move in this direction, but looking at the reactions on social media and chatting with people, it's very interesting to note where the protest is coming from. A lot of it seems to be coming from our rural colleagues. And I was trying to think about why this might be. And I think as family doctors, we're good at sort of reading cues and so on. And it seems to us that there's a lot at stake around pride. Our rural colleagues have a great deal of self-invested energy to be able to practice rurally. I mean, I remember as a graduating resident, yes, of course I felt competent. I was coming from U Ottawa, great program, but I had to do a whole ton of courses on my own, ATLS, ACLS, PALS, neonatal resuscitation, ICU, right? Those I won't say what kind of rotations. And so why don't we say, yes, we're not trying to remove your agency, but we're trying to give you the actual support. We're going to fund your PALS. We're going to fund your ATLS. I'm not sure where the money's going to come from, but you see my point. We're going to actually do this for you, not to remove your agency or pride. It's amazing that you have the agency and pride to actually want to do this, but we're going to actually support you to do it and make that ICU elective more affordable and not have you on call the first night. And we're going to somehow fund your ATLS, ACLS. And I think that's going to speak a lot to this question of pride that I'm reading between the lines. And that's also relevant to the enhanced year. Thanks very much.
Lots of interesting points, David. And I think we could talk for a long time about, each one of them. Certainly when we did the road shows in our more rural teaching practices, units, there was an appetite for this. And I'll say every single unit we went to, every road show, there was, a good 20 minutes of what the heck. And it's already tough enough and it's chaos. But every single road show that we went to, we put a green light afterwards that people understood the goals, the intent, and the advantages that it was to them. And I think part of this is you don't know what you don't know, right? So if someone comes in and is able to say, this is what the goal is, and, yes, it's going to be problematic. People are not going to want to do a 3-year, but at the end of it, you're going to be more prepared for the complexity. So hopefully you're going to feel more at ease. You'll have more wellness when you come out. There's an ability to have increased access, increased efficiency, increased effectiveness. That first 5 years is not going to be such a challenge for you. At the end of every one of those sessions, people were in a green light position, and our rural colleagues were saying, send your guys to us. We will send our residents to you. And I think for me, it always comes down to making sure the message is correct and that people understand the intent and can then lend their voice to how this is going to play out in our community. And the college is very clear about that, is we design this for our context.
Yeah, Claire has a comment, but it also really gives the imperative to look at competency-based education and graduation, right? And I'm not aware of the current discussions on that, but maybe this is a point to make. Like, an enhanced year might not be necessary if all the competencies are met after the core 3 years for a resident who's interested in intrapartum OB. I think that's an important point.
Well, I think the interesting thing you have to note also in the model is that there's the core, which is the beginning triangle at the top, and then there's the transition to practice. And this permits us for the resident that is, needs the enrichment right from the beginning, because on that first rotation, you're writing, oh, they're functioning as a PGY2, that opportunity to start doing a lot of that enrichment before that 3rd year period. Whereas the residents that are struggling a little bit more will have an ability to be accommodated, somewhere within that beginning of the 3rd year into the 3rd year. So it gives us a leeway to really enrich the experience of that, PGY2 that is functioning at the level of a graduate, and providing them with the opportunity to lead more clinics, to be, participating in more teaching, and then have more exposure to things that they may not have even thought of. And for me, I suspect those are where we're going to get our next academic teachers, right? Okay, Claire. Sorry. Thanks
No
for your
problem.
patience.
Sorry, I'll try and be fast, but of course now I've accumulated 4 points. The first is just around the 3rd year family medicine, right? I'm trying to look at the data now. Hopefully we'll know a little bit more soon, but my gut is that most people who do a 3rd year do not actually practice comprehensive family medicine for the most part. They go on to practice focused practice, right? So we have to, I think, acknowledge that. Having said that, recognizing that it's been an important piece for people, I'm curious to know if there might be, because I think a piece of it is the focused practice designation that they get for a couple of the programs, right? And would there be the ability to design our 3rd year to incorporate some of these people who want to do focused practice and still allow them to receive the designation which is really what they want? Third is just thinking a bit about the rural context. And, there's certainly, we've seen in the media over the last few days, rural physicians are saying, like, we train residents really well. They are practice ready. We need them to fill our gaps. We are drowning here. Is there a way to very, very intentionally partner with some of our rural communities? I'm sure you've already done that. I know Eric was sharing some of that, but just to figure out how we can both fill the gap there and facilitate this training, right? Because, I worry a bit about a patriarchal, I guess, for lack of a better word, relationship with them, like that we in the urban centers know best, when really actually we're struggling to train residents as well as we could or should. On that note, just very, very briefly, I think there could be the potential to partner with Nunavut around having that 3rd year have a chunk of placement that could occur in territory where, which is what they want. Actually, they want people there for longer because they're more likely to practice longer. And I am confident that we have the relationship to do that. I've already initiated the discussion, so happy to carry that forward. I think Ed, I sent you an email on that a while ago. So that's something we could actually look at doing.
And could look at doing right now, right? I mean,
we could look at doing it right now. Yeah, for sure.
So we can move forward. Yeah.
Because they can actually have in territory now, they have the capacity to do rotations in surgery, emerge, family medicine, peds, and likely soon OB.
Great, thanks, Claire. Wonderful point. I will go to Parissa because you had your hand up for longer, and then after that, Claire Liddy.
Yeah, I was just raising my comment. Actually, I put a comment on the chat. So I presented at the college about 5 months ago on the women's health curriculum that I've been very privileged to develop through the Generous Innovation Grant. And I'll be presenting next month our actual survey of our own faculty members who do gynecologic procedures, which is actually quite alarming. So I'm wondering, how do I then put a proposal in to incorporate that? Essentially, the curriculum is completed. We have a blended model, which has the virtual assessment tools I've created and validated and will be publishing, and it's actually coming out. The DOI is waiting. So we have everything How do
Perfect.
we get it in the hands of our learners so that we actually optimize even their current education,
Right.
without necessarily increasing the years, because even the current ones are concerned about their current curriculum and their skills.
Right. And again, we're not changing process here. It's still, our director of curriculum is Denise Lewis, and, you go through the program director Ed Seal, and it's presented at the post-grad, group. There are ways of getting it in, and certainly everybody is looking to have those resources readily available. Certainly the college is surveying us for anything that we have that would meet the gap domains right now, so that we can share across the country who are the expert, where are the curriculum already set up, and how can we incorporate them as a university that may not have that already within its curriculum. But certainly talk to Denise, send a note to Outcomes of Training, because we, as I said, have this repository of things we're putting together as great ideas, innovations, partnerships, pilot projects. But Denise and Ed are still those people that we go to share that kind of packaged, ready-made modules, resources. Thank you for that, though. That's wonderful to know. I may call you just for the Riverside for that information. Claire, and then Matt after that.
Yeah.
I think we're almost done, aren't we?
We are done. Yeah. Great discussion. Thank you. I'll respond on the rural and the engagement in the community. We've already begun that. In fact, I was in Winchester this week hearing about Morrisburg. They have no family doctors. How do we combine their needs with then sort of our program changes? So very open to that. We're going to invest in community clinics. So we're looking for 6 community clinics to be working with us. We already have, I think, 3 identified. So a lot of opportunity. And I think, again, just reiterating that, we are doing reform of our program already and thinking outside of the box, all with a view that, then when this would actually get implemented as a new standard by the college in the future, that, Ottawa is already up and running. So it's a great opportunity. And I think looking for more resources, money, people, time to basically be able to do these. So I think it's very exciting, and I love the Nunavut concept. We had been thinking about that more locally as well, but definitely we'll do a follow-up.
So I guess the last word's going to go to Matt.
I just wanted to, I guess I'm going to ask something similar to what Dr. Rezaifer had mentioned and was talked about so far, but just really wondering what that curriculum reform for the initial 2 years is going to look like. Just in talking to some other staff about this and hearing other people's thoughts, I think a good point that's been brought up is that we haven't optimized the effectiveness of the residency, the 2-year program in Ottawa yet. And there are things that they've been trying to change for years, like essentially the amount of CTU and the amount of L&D that we do as residents, that just haven't been able to be changed, and that take away from other learning opportunities. And I just think about colleagues of mine in other programs, like a friend of mine in Toronto Western, who has a lot of elective opportunity to pursue his interests that contribute to his comprehensive family practice, and how in his program, a lot of them do feel pretty ready upon graduation to do that comprehensive practice that they want to do. And so just want to put that out there in terms of curriculum reform for the existing curriculum, because I think that's an important part if we're talking about expanding the duration of training, to also make sure we optimize what we're currently doing.
Yeah, no, that's the plan. And again, I would invite everybody to be a part of this, because as Doug said at the beginning, this is our department. You need to, if you want to you need to be a part of, your voice needs to be heard. And that does require a little bit of extra thinking. And, that's not so easy on a Friday afternoon when you've had a rough week. But certainly we appreciate any comments, criticisms, suggestions, and any certainly pitches for pilot projects. And it can be small. It can be something that just has been niggly in your community of practice, and you think, I just want to change this. And then you realize by pitching it that others have found exactly the same problem. So please, please, please get involved. We need you to make this better. And certainly we need a lot of content experts moving forward. And everybody on this call has got something that, we would appreciate being able to, tweak the curriculum with their input. So thanks everybody for listening. And, we will be coming to a roadshow near you soon. Please go to the, please show up at the retreat, because there's more of this discussion, and we'll be doing more work, this type of work that's really, really important.
And on that note, and I think that is a good note to close. Thank you very much, Madeleine. Thank you, Claire. Thank you, everyone, for your participation. We'll keep track of these comments. This all gets worked into our reports. And if there's questions here that weren't answered, I'll see that they do get answered. Please continue the conversation. On that note, thank you very much for attending, and look forward to seeing you in October.